The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. The show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join. Hit me.
Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults. Shorts. This is Senior Rehab Shorts, the evidence-based segment for geriatric rehab clinicians, bringing you relevant and applicable content to better serve your patients, regardless of your setting. And now your host, Joe Daniels.
Hello, friends, and welcome to another episode of Shorts. This is the second evidence-based episode, and today we are talking about knee osteoarthritis in the older adult. So I don't know about you all, but this has certainly been one of the most challenging diagnoses for me to get buy-in, especially with the older adult population, and more so in my current outpatient orthopedic rotation, just because of the amount of folks bringing in imaging and having those pain catastrophizing thoughts of what they see on imaging and how to get buy-in and what the evidence says with regards to the ability of exercise to really improve the symptoms that are caused by these degenerative changes. So I wanted to know what evidence, if any, was out there regarding the efficacy of physical therapy with regards to knee OA and what interventions were most effective, both in the short term and in the long term. So this week's paper is also out of the Journal of Geriatric Physical Therapy from volume 39, issue number 1, and it's the January-March edition of 2016 by Anwer et al., and that's Anwer. And it is titled, The Effect of Home Exercise Programs in Patients with Knee Osteoarthritis, a Systematic Review and Meta-Analysis. So let's go ahead and get started with some introductory information here. Knee osteoarthritis, or OA, is a major cause of musculoskeletal disability in the older adult population, affecting both men and women, and is reported by the World Health Organization on the global burden of disease. So knee OA causes pain, joint stiffness, and decreased quadricep strength, resulting in physical disability and disease progression, with models showing a decrease in the Western Ontario and McMaster osteoarthritis, that's the WOMAC, W-O-M-A-C, scores by 1.77 units per year in most of the knee OA population, leading to rapid progression and often, and most times, knee arthroplasty. So reduction of pain and improvement of function are the main aims of any treatment approach in the management of knee OA. Combinations of treatment approaches, including both pharmacological and non-pharmacological methods, are often preferred over a single approach according to the evidence here. All right, so let's get started here. So both rehab programs with and without supervised clinic-based exercises have been shown to reduce pain and improve function in individuals with knee OA, although home exercise programs have advantages over supervised clinic-based programs because they're less expensive and obviously require little to no equipment. And then concerns arise about long-term compliance of home exercise programs, with that being one of the main issues as to perhaps why people aren't healing the way that they should be. So in a prospective long-term study conducted by Deal et al., the effects of a home exercise program on lower extremity function were almost equal to those of supervised clinic-based exercise programs, even at the 1-year follow-up mark. So past studies have pretty much, according to what I found in the literature here, consistently shown that a home exercise program is beneficial for improving strength, reducing pain, and improving function in individuals with knee OA. However, there has yet to be a systematic review of the literature nor a meta-analysis nothing's been published on the effectiveness of a home exercise program for the management of these individuals. So obviously the objective of this systematic review is to investigate a little deeper into those findings and what cumulatively does the evidence say. So in terms of the methods for this specific paper, they searched in PubMed, CINAHL, Embase, Scopus, and Pedro using a combination of keywords such as pain, exercise, home exercise program, rehabilitation, supervised exercise program, and physiotherapy with osteoarthritis of the knee, and the medical subject headings, osteoarthritis knee combined with exercise or rehab. So there's a ton of different terms they used to find this big body of literature here. The bibliography survey, however, was restricted to randomized and case-controlled trials published in the English language prior to September 1st of 2014. So I'll talk a little bit about the downside of the types of trials in this paper later, but obviously it's not always the strongest evidence individually, but if you throw it all together, and that's what the summary or the summary body conclusion comes to later, is that, individually this evidence isn't that strong, but consistently having the same results and putting that in a big pile is obviously going to put the evidence strength at a lot higher up in the chart there. So in terms of inclusion and exclusion criteria, obviously there are some limits by design, as only randomized clinical trials and case-controlled trials were included, obviously, like I said, prior to 2014. And then the interventions of interest were home exercise program for individuals with knee OA. And the outcome measures of interest were pain and function in patients with this diagnosis. And then randomized control trials were excluded if the publication was only in abstract form. So in terms of assessment of the methodological quality, or the Pedro scale was used to assess that quality. And the scale consists of 11 questions that assess the quality of randomized control trials and focus on two aspects of the study. So one, whether or not it has internal validity, and then whether it contains sufficient statistical information to make it interpretable. So in accordance with Mosley et al., studies with a score of 5 or 50% or greater were considered high quality. So in the present review, all randomized control studies or all randomized studies with scores of a 5 or greater were considered to be of high methodological quality. And in the end here, it basically ends up saying that most of the studies, I think 17 out of the 19, were high quality in nature. So in terms of the results here and the identified studies, the initial search resulted in 65 research studies, and then a total of 34 studies appeared in more than one database or did not meet the inclusion criteria, and hence were excluded. And then a total of 31 studies were assessed for eligibility. So 12 of those were eliminated because they didn't match the inclusion criteria or were not available in full text. And then the final selection made by the consensus resulted in the inclusion criteria, or the inclusion of 19 total studies in the quality assessment phase. So in terms of that quality assessment, the 19 studies had an average Pedro score of 6.78 out of 10. Remember, we just said 5 out of 10 or greater was considered high quality evidence. So we're looking at some pretty solid stuff here. With the most common shortcomings being lack of blinding, so both the patient, the therapist, and the assessor, and lack of concealed allocation. So just a few numbers here. Three trials failed to meet randomized criteria, 6 trials failed to meet intention to treat, and then 1 trial failed to meet the baseline comparability criteria of Pedro. 5 trials failed to meet the follow-up, and point out variability measures in terms of Pedro criteria. What does this all mean, right? So basically what the conclusion was is, however, when these studies were examined together, like I mentioned previously, there was a strong scientific evidence from high quality studies with consistent results that the home exercise program brought significant improvement in individuals with knee OA. So obviously there was some little there were a few errors going forward with the way that these things were put together, but not enough to really sway anything in terms of the conclusion of the total study. So in terms of the body of all of it put together, like I mentioned, it's very clear in terms of both the strength and the level of the evidence that what we're doing with these populations is effective. And then agreement between the evaluators was deemed excellent in assessing risk of bias across all these studies. So let's get into these a little bit. In terms of the actual components of home exercise programs included in these studies, there was a lot of variability. Outcome measures were pretty consistent, and then what they were looking at was pretty consistent in terms of pain and function. So in terms of interventions here with these systematic reviews, or this systematic review of all these different trials, the interventions used included a combination of open and closed kinematic chain exercises. 3 studies used muscle stretching of the quadriceps, the hamstrings, and the calf, in addition to range of motion exercises. 4 studies used balance exercises. 1 study used proprioception, cold compression, neuromuscular e-stim, and pedometer-driven walking, in addition to Tai Chi exercise. There's a lot of variability in terms of what was used out of these total 19 studies that were ruled in. But one key conclusion comes to mind. And again, that the purpose of this review is not necessarily to break down what was good and what was bad in terms of the intervention. It's basically, are we helping these people or not? And what is the level of evidence to get that buy-in to present to these folks? And so I'll break that down a little bit more here in a second. But in terms of outcome measures, the outcome measures of interest were, like I said, pain and function. 8 studies used the WOMAC. 7 studies used the visual analog scale, and 1 study used the McGill pain questionnaire. And then 1 study even used the Japanese knee OA measure. And then others used the WOMAC for function in addition to pain. So in terms of the effects of the home exercise program on pain, what was the conclusion there? So in terms of the meta-analysis of 11 trials, it showed that most study outcomes displayed effect size point estimates that favored home exercise compared with no intervention, with the test for an overall effect across 11 studies being significant. So with a p-value of less than 0.001. And then as far as pain goes, or as far as function goes, rather, effective home exercise program on total function, following a meta-analysis of 9 trials, basically showed the same thing in terms of point estimate, that home exercise compared to no intervention was clearly favored across all 9 studies, with it being significant as well, with a p-value of less than 0.001 again. And that was total cumulatively, regardless of the intervention there. So in terms of discussion here, the present review evaluated 19 studies, so 15 randomized control trials and 4 case-controlled studies, with a total of 4,270 subjects with knee OA, to examine the evidence regarding the effectiveness of home program in the management of this condition. So among the 19 studies evaluated using the Pedro scale, 17 were presented, or 17 of them were considered high methodological quality, and then on the basis of that, it's obvious in terms of conclusion that the home exercise program is superior to no intervention at all, and making differences in these folks. So in the present study, or in the present review, 4 studies failed to achieve a statistically significant effect size of functional score changes, and 4 studies on pain score changes. So I went back and looked at these studies that didn't achieve this statistical difference and tried to figure out why. And there was really no rhyme or reason why the results they got were the results they got, because there was no obvious differences in terms of sample size, or in terms of blinding or concealment, or really in method. So I'm not sure why that happened, but obviously the body of the evidence, with 4 out of 19 not being significant, 15 out of 19 is still a pretty strong number here. So this, in the present review, so the home exercise compared with other interventions showed that both interventions demonstrated similar effects on pain in 2 studies and on function in 3 studies. So what this also looked at is, okay, in terms of physical therapy setup. Are you doing this under a supervised therapist, or are you doing this at home? And what's the difference in those two settings in terms of outcomes and pain and function under those specific functional assessments that we spoke of in regards to the WOMAC and the VRS scale. So consistent with previous studies, basically the finding was that there was no statistical significant difference in functional improvement for older adults with knee OA when comparing clinic-based exercises with home-based exercises. Obviously, the key again, like I mentioned with balance in the last evidence-based segment, is that these exercises are being consistently performed, and that's really the take-home there. So in the present review, the group education or therapy along with home exercise compared with no intervention demonstrated significant reduction of knee pain and improvement in addition to function in individuals with knee OA. Regarding the assessed outcomes, the use of reliable and valid instruments in the studies strengthens the quality of the outcomes. The WOMAC index and the visual analog scale, not VRS, were the most widely used tools. And these tools in terms of knee OA are the most reliable and valid to assess pain and function. So if you're going to, treat folks with OA, I highly suggest you use those two tools as that's what the evidence said is most effective and reliable. So of the 19 included studies, only 2 of them reported the degree of knee OA included in the sample, and I'm not sure how relevant that is with imaging to decide, what's the degree, how bad is this OA. Just something they mentioned there at the end. So although wide variation was found in the methods and interventions used in these studies, most reported significant improvements in outcome measures following home exercise with and without a supervised exercise program. So whether you're in the clinic or at home doing this, the results are pretty much the same. There was considerable variation in the content and the duration of the exercise programs included in the systematic review. So the length of the intervention really drastically ranged as well, from 6 weeks to 2 years, while the home exercise programs included various types of exercises, as I mentioned previously, such as isometric quadriceps, isometric hamstrings, and then isotonic quad and hamstring as well, in addition to strengthening Tai Chi, range of motion, and resistance exercise. And again, if you want to dive into those studies individually, be my guest, but this is more of an overall presentation of what the evidence says, not necessarily specific to what interventions are making a drastic difference, because they all are making a difference in this case, since there was so much variety in the interventions with different studies here. The one thing that did stand out, though, is that the majority of the high-quality studies included a combination of open and closed kinematic chain exercises as home exercise program, and those were all consistent with the most positive outcomes. So I think one of the bigger take-homes here is to really focus in on a good variety with your program and making sure you're getting some functional closed chain exercises as well as, your regular open chain exercises for this population. So like I mentioned previously, adherence to the home exercise program is obviously a key predictor of response here, and encouraging patients with knee OA to continue exercise programs beyond that supervised period after discharge from clinic or what have you is obviously a challenge, and it's something that we definitely need to be addressing in terms of what the evidence says. So, hey, here's what the evidence says. I highly recommend that you continue this program going forward, or some of the results may suffer long term. So it's important to stay on top of that stuff. And then the validity of the present meta-analysis may be low due to the heterogeneity in the design and the choice of the outcomes of the included study. So, for example, the total intervention duration varied between 6 weeks and 2 years, and the sample size of these studies varied anywhere from 25 subjects to over 2,200 subjects. So another limitation is obviously the variation in outcome measures selected. Although pain and physical function were the main outcomes reported in the majority of the studies, no studies focused on the dosimetry of the exercise, like I mentioned, whether that be frequency or intensity, duration, or resistance. And obviously those weren't analyzed in this review. So one of the conclusions, obviously, is that future high-quality studies are definitely needed to assess which duration or dose or type of exercise are optimal for patients with knee OA, or if lifelong exercises are needed, to maintain these benefits of exercise, as I just talked about. So in conclusion here, based on the high methodological quality of the studies included in this systematic review, it can obviously be concluded that home exercise programs reduce knee pain and improved function in individuals with knee OA. And then the large evidence base supports the effectiveness of a variety of home exercises, including both open and closed kinematic chain exercises, in addition to small, but let me back up there. In addition, small but growing evidence supports the effectiveness of other types of exercises, like Tai Chi, like balance exercises, like proprioceptive training for individuals with this disorder. And not that anything specific was mentioned in this study. That was just a few of the studies included in the review that focused on some of those things and had some positive results, although not necessarily major in sample size compared to some of the other ones that we typically see, like stretching or strengthening. So even though less is known about the effects of these types of exercises, they do provide some new alternatives maybe for individuals with OA to modify, vary based on their exercise program. And then further direct comparison is required to investigate the relative efficacies of these exercise programs compared to what we're normally doing. So in terms of takeaways, obviously group education or therapy along with the home exercise program compared with no intervention at all obviously demonstrated a significant reduction in knee pain and improvement of function in individuals with this condition. 2, there was no difference in functional improvement when using clinic-based exercises versus a home exercise program in older persons with knee OA. 3rd, the WOMAC and the visual analog scale are obviously the most reliable and valid tools to assess pain and function in individuals with knee OA. And then last but certainly not least, the majority of high-quality studies included a combination of open and closed kinematic chain exercises into a home program, all with consistent outcomes. So I think if I were reading this, that would be, those would be my biggest takeaways, but specific to the combination of the open kinematic chain exercises and the closed. You get a good balance of both of those in there, and I think you'll be in good shape. So that's it for this one. Next week, the article is Challenged and Changed in Acute Care Through Evidence-Based Practice, and that's by Rick Ward, who's a PT, a geriatric clinical specialist, as well as a certified wound specialist. Rick is a graduate of Texas Women's University and has been practicing in the acute care setting for 21 years. Currently a senior acute care PT at Wise Health Systems in Decatur, Texas. So really looking forward to hearing some of his perspectives on that. And then the following week, which will be the 3rd evidence-based episode, is a brand new 2017 paper, again out of the Journal of Geriatric Physical Therapy. And this one's an absolute monster, guys. You're not going to want to miss this. So until next week, stay funky, my friends.
Hit me. Thank you for listening to the Senior Rehab Podcast. I appreciate your time. And if you enjoyed this episode, do me one favor. Share it with one other person that would benefit. Thank you. If you want to see the show notes or find more episodes, just go to seniorrehabproject.com. And until next time, my friends, do not forget to stay funky. The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. The show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join.